Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. Today we'll be discussing on one of the another useful topic, very frequently asked as a full question, pericardial effusion. Majority of the point we have already discussed in pericarditis. Some of those will be repeated again. And we'll be also taking one another topic related to pericardial effusion is cardiac tamponade. We'll be talking that separately. We'll be discussing under heading definition, etiology, pathophysiology, clinical features, investigation, differential diagnosis, treatment and complication. Definition is very simple. Pericardial effusion means abnormal accumulation of fluid in pericardial cavity, or we call pericardial sac. Or we say that if fluid collection exceeds 50 ml in pericardial sac, it is usually defined as pericardial effusion. While cardiac tamponade is a clinical syndrome caused by accumulation of fluid in pericardial sac, resulting into reduced ventricular filling and subsequent hemodynamic compromise. Now here the quantity is not fixed. If there is a rapid accumulation, even 100 ml can produce cardiac tamponade. And if there is a gradual accumulation, it will be a huge quantity. So depending upon the intrapericardial pressure, if there is a reduced ventricular filling and there is a hemodynamic compromise takes place, then it is called as cardiac tamponade. We have shown you this slide before. You can classify pericardial effusion into acute, subacute and chronic. Depending upon the quantity of fluid, mild, moderate and severe. Or we say that depending upon the intrapericardial pressure, you can call that as mild, moderate and severe. Distribution wise, circumferential means total, and in a small area we call loculated. Etiology wise, bacterial, tubercular, viral, fungal, amoebic, etc. That will be dealing again in detail in etiology. Depending upon the type of fluid, transudate, exudate are the two common words, but we can further divide transudate as hydropericardium, exudate as effusion, blood we call hemo, and collection of a chyle we call as a chylus. Very rarely you can come across odd materials like amoebic pus. Not very common. Acute, subacute and chronic we call as low pressure, regional word is utilized in loculated variety. Pericardial compression syndrome you can divide into three groups: cardiac tamponade, constrictive pericarditis and effusive constrictive pericarditis. Now this is one of the classification which is very frequently utilized, where you grade them into three: less than 200 ml, more than 200 ml, and depending upon the mean arterial pressure, central venous pressure, heart rate and presence of Beck's triad. So depending upon that, it is classified into grade 1, grade 2 and grade 3. This is cardiac tamponade, and this too, less than 200 ml, grade 1, less than more than 200 ml or equal to 200 ml, grade 2. But here, if you see the heart rate, there is tachycardia, central venous pressure is 12 or equal to 12, and Beck's triad, may or may not be present, but here it is always present. Now person starts developing bradycardia because of development of the cardiac tamponade and central venous pressure almost close to 30, between 30 to 40, and cardiac output will fall, mean arterial pressure will also fall, person will have a severe hypotension. Acute is more than 150 ml and chronic can be as huge as 1 liter or maybe more than that also. And when it goes to 2000 or we call 2 liter, it becomes extremely dangerous one. Etiology wise, we have already told you infective, autoimmune, neoplasm, radiation, traumatic, renal failure or uremic, idiopathic, which is accounting for almost 85 to 90%, drugs and endocrine disorder, particularly mixed edema. Most common are three most common: idiopathic, infective pathophysiology and neoplasm. These three comes topmost on the list. So if you combine these three, almost it will be accounting for nearly 99%. Autoimmune, uremic, drug-induced, mixed edema, radiation pericarditis, traumatic, etc. will be a very small group. We have already discussed this in a pericarditis chapter, that is etiology. Idiopathic comes topmost on the list, which is almost up to, we have already shown you, 85 to 90%. Infective etiology comes second and neoplasm comes third. So these three will be accounting for almost 98 to 99% and rest are all this other. So these three comes topmost on the list. And in infection, viral and tubercular comes most common, and then comes bacterial, fungal, etc. Fungal is most common in an immunocompromised host. And neoplastic is very frequently metastasis. Primary tumors are very rare, and usually there can be extension from nearby structures like lung, mediastinal structures, etc. So at your leisure time you can go through, these are in detail. These are second way: infective, malignant, inflammatory and intracardiac pericardial communications. These are all the different etiology at your leisure time. If you are interested, you can go through. This is another group. Some of the common like hypothyroidism, trauma, pericarditis, myocardial rupture, after heart surgery, aortic dissection, etc. We have already discussed and we have shown this slide before that after pericarditis, either because of inflammation or because of malignancy or maybe autoimmune drugs, etc., there is a little accumulation of a fluid we call pericardial effusion. Depending upon the onset, usually in acute it will be rapid, in a chronic it can be massive. When there is a rapid accumulation, the intrapericardial pressure, so that is the pressure in the pericardial sac, rises very fast and it can give rise to tamponade. While in a chronic variety, there is a gradual accumulation, and when it exceeds certain level, there is a elevation of intrapericardial pressure, and that can also end up with tamponade. Usually in a chronic onset, or we call slow filling, or we call gradual, depending upon the quantity, we divide into mild, moderate and severe. I have already shown you one slide before. By and large, hydro will not end with fibrosis, so there is usually, it does not end with constrictive pericarditis. In transudate also, usually we don't come across any fibrosis. Exudate invariably will end with fibrosis, so bacterial, tubercular very frequently will lead to fibrosis. Viral usually does not end with fibrosis. Radiation malignancy can end with fibrosis. Tuberculosis can end with calcification of pericardial layer, thickened pericardial layer, and it can end finally into constrictive pericarditis. Hemo will develop bacterial infection secondarily and then can end into fibrosis. The route of entry we have already discussed in pericarditis by continuity from lung and pleura, most common, from mediastinal structures like esophagus, aorta. It can extend from myocardium or may also extend from mediastinal lymph nodes. Most common route is hematogenous spread, which is very frequently in septicemia, secondary due to toxins or secondary metastasis, or maybe because of metabolic cause like uremia, elevated urea level. Lymphatic spread is very rare. Usually lymphatic spread will be very frequently in case of secondary metastasis and in case of tuberculosis. Traumatic injury and irradiation can also involve pericardium by direct injury. We have already discussed this particular in pericarditis, early stage, progressive stage, and finally what we call is a constrictive pericarditis. So I am skipping over this particular, we have already discussed in this lecture also. Infective pathophysiology ends with inflammatory response, influx of neutrophils, chemical mediators, increase in permeability, pericardial inflammation, and exudation of fluid leading to pericardial effusion. Now this pericardial effusion can completely recover or may go into what we call as an acute accumulation cardiac tamponade, or because of gradual accumulation also it can undergo cardiac tamponade. And in some of the cases like bacterial pericarditis, tubercular pericarditis, radiation, traumatic injury, malignant, it can undergo fibrosis and it can end with constrictive pericarditis. In some of the etiology you can get a relapse or we get recurrent episodes. Recurrent episodes is very common in tuberculosis, malignancy, and also in case of idiopathic groups. Depending upon the type of etiology, it can be transudate. Very frequently, classical example is heart failure, hypoproteinemia. In pyogenic infection, usually transmitted by hematogenous or by contiguity, it will be exudative fluid. In traumatic injury, very frequently hemorrhagic fluid. Also in case of malignancy also it can be hemorrhagic. In this particular condition it will invariably end into what we call as constrictive pericarditis. Rapid accumulation of a pericardial fluid can end up with increased pressure in pericardial sac or we call pericardial cavity. Because of increased external pressure, ventricle is not allowed to relax during diastole. Hence, the filling of the ventricle during diastole is poor, which will end into decreased stroke volume during systole, and there will be fall of blood pressure. And if there is a rapid accumulation of fluid, this fall of blood pressure may be significant enough, leading to cardiac tamponade. So that will end into decreased cardiac output and fall in systolic blood pressure. And that will be very peculiar finding in case of cardiac tamponade. So this is the mechanism. Indirectly, this will be discussing again in a cardiac tamponade, that at the end of expiration, right ventricle and left ventricular volume is almost equal and pulmonary pressure is 15 millimeter. Right ventricular pressure is also 15 millimeter and external pressure is also 50. During inspiration, the pulmonary pressure falls, right ventricular pressure falls by 1 millimeter, Pericardial pressure also falls. Now because there is an external pressure being little higher, now right ventricle is not allowed to relax, and as right ventricle is not allowed to relax, when there is a venous return from RA to RV, right ventricular volume will increase, which will shift interventricular septum towards left ventricle. So during inspiration, you can see that the left ventricle volume is reduced. So cardiac output will be reduced. And because the cardiac output is reduced, the pulse volume will reduce. And this will produce classical pulsus paradoxus. During expiration, now pulmonary pressure rises. As pulmonary pressure rises, there is also elevation of what we call as output from lung into LV, which will increase the left ventricular volume, which will elevate your cardiac output. So pulse volume will increase, pulse will reappear. There will be compression of a right ventricle because now interventricular septum will shift towards right side. That will decrease the right ventricular filling, and pressure in the right ventricle will increase again to 15 millimeter, and that pressure and pericardial pressure will be equal. This will result into reappearance of pulse during expiration. So pulse disappears when the person take a deep inspiration and holds the breath, and when he does a forceful expiration, the pulse volume will come back. This is typical pulsus paradoxus, which will happen in a person with cardiac tamponade. So very peculiar of pericardial tamponade. There is a shift of septum during expiration towards the right side, and during inspiration it is shifted towards left side. That will produce fall in cardiac output from left ventricle during deep inspiration. So I have already explained that particular part. This slide also I have explained you during pericarditis, that because of increased collection of a fluid in pericardial cavity, there is increased pressure on the right side of the heart, decreased venous return. Because of decreased venous return, there is a pooling of the blood in pulmonary capillary, which will produce decreased stroke volume, decreased cardiac output, and sometimes because of severe fall in cardiac output, it can end into cardiac arrest, and this can happen in cardiac tamponade. As far as symptom is concerned, it will depend upon the type of inflammation, severity of inflammation, quantity of inflammation, or quantity of collection of a fluid in pericardial sac, and speed of formation of pericardial fluid. If the speed is very more, even a small quantity can produce increased pericardial pressure, intrapericardial pressure. And if there is a large quantity of fluid which is accumulated in pericardial sac, now stretching of the pericardial layer will not take place, and there will be elevation of intrapericardial pressure resulting into constrictive pericarditis. Here the person will invariably, good number of time when there is a gradual accumulation and small quantity of fluid, they are usually asymptomatic. Because of basic etiology, person can have fever. They will complain of pericardial pain. Usually it is a dull aching pain. Once the fluid is accumulated, there is no pericardial friction rub. And usually we don't see ST segment elevation in ECG once there is a pericardial fluid which is being accumulated. And now you will see low voltage and tachycardia. And in case of pericardial tamponade, you will have a low voltage with pulsus alterans, and in ECG electrical alterans. So that will be the most common way in which the person will present to you. So by and large, the person can come to you with a cardiac tamponade or chronic symptom signs of pericardial effusion, and in the end stage, person can present as a constrictive pericarditis. This will be discussing separately, constrictive pericarditis, in a separate chapter. Because of gradual accumulation, external pressure on the right ventricle and left ventricle, the feeling is poor, cardiac output is poor. Hence, the person will complain of chest pain because of pericardial inflammation, dyspnea, dysphagia, hoarseness of voice, and he might also have hiccups. This will be because of compression of the esophagus and compression of the recurrent laryngeal nerve, which can happen. And hiccups will be very frequently if the diaphragmatic pericardium which is inflamed. Now, because of accumulation of the fluid in the pericardial sac, the heart sounds are soft and muffled. Rub will be absent, or we call disappears. And on percussion in a lung, posteriorly you will get Ewart sign, that is lung dullness on the left side infrascapular region because of atelectasis. That is because of the pericardial effusion producing compression of left lower lobe lung. We call Ewart sign. So person very frequently will present with breathlessness, chest pain. Abdominal pain is because of liver congestion, fatigue, fever if it is infective pathophysiology, cough, palpitation, and very frequently in a constrictive pericarditis, person may have hypotension and even in a shock stage. So tachycardia, muffled heart sound, JVP elevated, fall in blood pressure. These are the very peculiar signs seen in a cardiac tamponade. And you will have a pulsus paradoxus or paradoxical pulse. During inspiration, there will be fall of blood pressure more than 10 millimeter of mercury. We considered that as pulsus paradoxus. There is one clinical sign we call as a Beck's triad, which is a very characteristic of a cardiac tamponade, which includes pulsus paradoxus, hypotension, syncope, elevated JVP. We'll be showing you that slide. Pericardial friction rub will be invariably absent. Person can have tachycardia. Hepatojugular reflex is secondary because of increase in right atrial pressure. In respiratory system, tachypnea, dyspnea, hoarseness of voice is quite common. Decreased breath sound because of pleural effusion. In GI tract, there is hepatosplenomegaly, which is more of congestive variety. Hiccups is because of the irritation of diaphragmatic pericardium. Dysphagia and nausea can be there. In CNS, person can have anxiety, confusion. Because of decreased cardiac output, peripheral pulse will be low volume, and person can also present as peripheral edema. Beck's triad, typically we call three signs: hypotension, JBP elevated, and muffled heart sounds. This is very frequently either because of a rapid accumulation of pericardial fluid or because of large quantity of fluid accumulated in pericardial sac. So increase JVP, hypotension, and muffled heart sound. So these are the three common classical findings. They also use, they call 3Ds. D1 for distended vein, that is because of increased venous pressure, we call raised JVP. Decreased blood pressure we call as hypotension, and decreased heart sounds on auscultation, or we call muffled heart sound. You can remember whichever way you want. It is hypotension, elevated JVP, muffled heart sound. So these three are the classical finding which we come across together. That is we call as a Beck's triad. And on pulse examination, there will be tachycardia, low volume pulse. You can have tachypnea, diaphoresis, cold clammy extremities, cyanosis may be present. You will get pulsus paradoxus. On palpation in cardiovascular system, even the apical impulse may not be able to locate. We say that apical impulse is not localized. You cannot identify. Friction rub is always absent. When you start getting constriction, you can get pericardial knock, and because of elevated pressure, person goes into failure. You can have a S3 sound, third heart sound. There is one more sign which you can see good number of times, we call Kussmaul signs. There is paradoxical increase in JVP elevation during deep inspiration. We call that as a Kussmaul sign. This is very peculiar in case of constrictive pericarditis and massive pericardial effusion. Ewart sign, we have already mentioned that on percussion, there is a dullness which is demonstrable on the left side posteriorly in infrascapular region. That is typically described as a Ewart sign. And on auscultation, you will get a bronchial breath sounds. This is because of compression, or we call atelectasis of left lower lobe because of pleural effusion. In JVP, you will have a A wave more prominent than C wave. That will be very peculiar. You will have a prominent A wave. This slide I have already shown you before. This is a slide which shows you pulsus paradoxus, that during deep inspiration there will be fall in systolic blood pressure by more than 10 to 20 millimeter of mercury, and that we call as a pulsus paradoxus, which is characteristic of cardiac tamponade. Three classical signs: distended neck vein, hypotension, and muffled heart sound, typical of cardiac tamponade. This is a difference in tamponade, constrictive pericarditis, restrictive cardiomyopathy, and RVMI. If you are interested, at your leisure time, you can go through. Just one important thing, in cardiac tamponade, pulsus paradoxus is very, very common. In constrictive, we can't demonstrate pulsus paradoxus. Usually in restrictive as well as RVMI also, it is extremely difficult to demonstrate. Kussmaul signs will be present in cardiac tamponade, will be also present in constrictive pericarditis, but it will be absent in case of restrictive cardiomyopathy. So some of the peculiar signs can be demonstrable. While you want to undergo approach to pericardial effusion, echocardiography is a very, very useful tool, will be helping you to differentiate. Clinical picture is extremely difficult unless you demonstrate a muffled heart sounds, absence of friction rub, elevated JVP, pulsus paradoxus, which is more when you get intrapericardial pressure being high, then only. And on ECG, you will get a sinus tachycardia with low voltage. And when there is a good amount of fluid being accumulated and you get a cardiac tamponade, you will have electrical alterance. This is very, very late. But on echocardiography, it will be very important to demonstrate a presence of pericardial effusion and severity of pericardial effusion. And you can even find out the diastolic period in RV as well as LV. With Doppler use, you can find out the amount of intrapericardial pressure, RV pressure, LV pressure, RA pressure, etc. Cardiac catheterization will be useful to find out the RA pressure, also pulmonary pulse pressure. You can demonstrate pulsus paradoxus, and you can even calculate the intracardiac diastolic pressure. All this can be investigated. On X-ray chest, you will have an increase in size of the heart, we call cardiomegaly. Usually with a pericardial effusion, it will be a flash shape, or we call bottle shape or pear shape. Cardiac pulsation will be absent because you cannot demonstrate that in presence of adequate quantity of fluid in pericardial sac. It is extremely difficult. Echocardiography will be most informative. To find out the type of a fluid, you will require pericardiocentesis and analysis. Different investigation may be needed to find out the basic etiology, and in some cases you might require even a biopsy, particularly in case of tuberculosis, malignancy, etc. CBC will help you to differentiate between infective and non-infective pathophysiology, bacterial and viral. In bacterial, leukocytosis; in viral, lymphocytosis with neutropenia. So neutrophil count will be less, lymphocyte count will be high, and you will have a leukopenia. Renal function test and liver function test will be useful in a case of a cardiac tamponade as well as in a person who has got a chronic massive pericardial effusion. PT and INR is useful to rule out the bleeding disorders as well as effect of chronic hepatic congestion. Troponin and CPK-MB will be elevated in a person who has developed myopericarditis. He has got myocarditis with pericarditis. ANA-assay for collagen disorders will be useful to rule out collagen disorder groups. ESR-CRP for biomarkers for inflammations, or we call inflammatory biomarkers. HIV testing, Montauk's test will be useful to find out the specific etiology. HIV for ruling out HIV infection and Montauk test for tuberculosis. And pericardial fluid examination will be very, very helpful. So pericardial fluid will be very helpful in that ADA will help to rule out tuberculosis, and looking for malignant cell will help to rule out malignancy. CT and MRI will be helping to identify cardiac tamponade, pericardial thickening, calcification, etc. You can see this is water bottle appearance, huge pericarditis. In ECG, we have already told you 4 stages. Stage 1, you will have an ST elevation, PR segment downsloping, ST elevation with concavity upward. Stage 2, concavity will come back to normal, ST segment will become isoelectric. In stage 3, you will have a T wave inversion, and in stage 4, T wave will again become upright. You can go through at your leisure time. Once the person develops a pericardial effusion, there will be low voltage, very peculiar with tachycardia. And in case of constrictive pericarditis or with cardiac tamponade, invariably we come across low voltage with electrical alterans. Electrical alterans will be very commonly seen. So you can see clearly alternate QRS complex, one with a good voltage, one with a low voltage. So this is called electrical alterans. And in a pulse you will get pulsus alterans. Echo will be most useful diagnosis, which will show you collapse of a right ventricle with swinging heart. So in that fluid, in this pericardial fluid, you will see that the heart is swinging. That is very characteristic. So we call pericardial effusion evidence, right atrial collapse, right ventricular diastolic collapse, swinging heart, very, very frequently seen. This. CT MRI will be helpful. In pericardial fluid, look for the cell count, look for the protein level, LDH level and ADA level, which will be very, very helpful to rule out bacterial, tubercular, viral, etc. And also you can go for viral culture, PCR, bacterial culture, and even smear for AFB. You can see calcification very frequently in a late stage of tuberculosis. You can see this is a calcified pericardium. You can see this calcified, very classical. You can see again this calcification. You can see in AP as well as lateral, both view you can see. In differential diagnosis, you should be able to differentiate infective, malignant, inflammatory, that we call as a non-infectious group. Also, you should be able to differentiate malignant, which can be primary, can be extension or secondary metastasis. These are the different conditions: idiopathic, tubercular, purulent, malignant, and post-surgical. Difference in history, fever, pericardial friction, rub, chest pain, etc. At your leisure time, you can go through. This is again same. This is in a fluid examination. What you come across, say in tubercular, the leukocyte count will be increased, while in purulent, there will be marked increase in leukocyte count, blood culture will be positive, and volume is usually very large in these three groups, that is malignancy, tuberculosis, and bacterial infection. As far as management is concerned, pericardiocentesis and drainage is the first thing, and it is absolutely necessary in person with a massive pericardial effusion and cardiac tamponade. By pericardiocentesis, you should try to identify the basic etiology and treat the basic etiology. Once the person is having cardiac tamponade or he is heading towards constrictive pericarditis, you might require a partial or complete pericardiectomy. And in presence of massive pericardial effusion, you might require opening, creating an opening in pericardial sac and draining out the entire fluid, that is pericardiotomy. And you must have a regular follow-up to see that person is not going towards constrictive pericarditis. And in the people who are likely to develop a constrictive pericarditis, glucocorticoid is one of the treatment, or we call steroid should be given. Say in case of malignancy, tuberculosis, after recovery of bacterial, they are also heading towards constrictive pericarditis. In all these conditions, steroid is absolutely necessary. So oxygen supplement, fluid resuscitation, bed rest, elevation of limbs, pericardiocentesis, and as far as the drug is concerned, anti-inflammatory drugs like aspirin, NSAID, and colchicine. And if you don't recover with that, steroid may be absolutely necessary. In bacterial pericarditis, antibiotics. And you might do percutaneous balloon pericardiotomy to drain out the pericardial fluid. For draining, this may be done. And you can create a pericardial window surgically, either by percutaneous or by surgical, we call open. So in a mild asymptomatic variety, usually you may not require any treatment, and you can have a follow-up by echo. In medium to large variety, if there is no cause and if there is a cardiac tamponade, or if it is idiopathic, pericardiocentesis, you can create a window surgically or by what we call as a percutaneous balloon pericardiotomy can be done. If it is a known case with symptoms and signs, pericardiocentesis with drainage. If person is asymptomatic, treat the basic cause. You can use anti-inflammatory drugs like aspirin, NSAID, and also you can use colchicine. And if not responding, then you can go for diagnostic pericardiocentesis and then find out the etiology and treat the specific cause. Usually in a large effusion, more than 3 months, you should go for pericardiocentesis. And if there is a recurrence, repeat pericardiocentesis. And if there is again a recurrence, then you can go for pericardiectomy. So percutaneous pericardiocentesis, which is a blind procedure, it can be ECG guided, echo guided or CT guided. By and large they use echo guided very commonly. You can go for balloon pericardiotomy or you can go for surgical procedures where you create a pericardial window, or you can go for complete what we call as a pericardiectomy, and pericardiectomy is very frequently indicated in constrictive pericarditis. So you can go for close or open pericardiocentesis followed by balloon pericardiotomy or surgical creation of pericardial window. So this is subxiphoid procedure. This is from parasternal region and this is from apical. You go from apex. This is from parasternal and this is from xiphisternal region. And most commonly what is being utilized is echo guided. So this is subcostal approach, this is apical approach, and this is parasternal approach. This is parasternal, this is subcostal, and this is apical. Pericardial window can be created by balloon dilatation or subxiphoid surgical pericardiostomy, or sometimes they also use video assisted thoracoscopy with localized pericardial resection. Open pericardiostomy can be done. Very rarely it is indicated. There are a lot of contraindications. We call relative contraindication like coagulopathy, aortic dissection, etc. By and large, pericardial effusion can end up with an pericardial tamponade and end stage constrictive pericarditis. You can have complication because of pericardiocentesis like myocardial puncture, laceration. Vascular injury can be there to coronary vessels, intercostal vessels, and if you are going through xiphisternal approach, then you can produce damage to liver, etc. Parasternal approach, you can create pneumothorax, air embolism. When you produce a damage to the myocardium, you can end up with arrhythmias, particularly ventricular arrhythmias and occasionally supraventricular rhythms. Injury to abdominal organ mainly commonly is a liver puncture, and you can develop vasovagal response to pericardial decompression, and person can go into what we call as a vasovagal shock. Pericardiocentesis may fail to relieve the tamponade, and you can have that failure particularly in a loculated effusion or in a case of an acute hemopericardium. Take home message is rate of development of pericardial fluid will determine the symptoms and signs and management. Never give beta blocker and diuretic in suspected patient with cardiac tamponade. And pericardiocentesis is a life-saving in pericardial tamponade. So I end my lecture on pericardial effusion. It will be helpful. Almost 70 to 80% of this lecture will be repeated again in what we will be talking on next lecture, that is cardiac tamponade. And then last on pericardial disorders will be constrictive pericarditis.